better sleep, sharper focus, a healthier life. It all starts with how you breathe.
Welcome to the No One Told Me, the Airway Health Connection, the Untethered Way, where better breathing meets better living. I'm Dr. Meggie Graham.
I'm Dr. Liz Turner.
We're the co-founders of Untethered Airway Health Center,
on a mission to help you breathe freely and live fully through proactive airway health.
Whether you're a dentist expanding your airway expertise,
or a family looking to sleep and breathe easier,
you're in the right place.
Each week, we'll bring you bold insights, real-world stories, and expert tips.
All to help you take control of your airway health. Because when you breathe better, you live better. Let's get started.
Well, welcome back, everyone, to No One Told Me, the Untethered Airway Podcast. I'm so excited to have my dear friend Stacy Becker on today. She is an amazing dentist and one of the co-founders of one of the most influential parts of my professional journey, which is ASAP Pathway. I would do an intro, but I will do it no justice. So, Stacy, tell us about yourself.
Well, hi, and thank you for having me. And that was super kind what you just said. The fact that we're so influential, ASAP has been so influential, Meggie, and you know this from, what you're doing and how you're influencing others. It's just like, some days you're like, am I really helping? And it's just so kind and so touching to hear that.
I mean it. Like, I can't tell you, like, there's like a couple big boulders that have been huge shifts and connectors for me in my career and what I do. And ASAP is at the very foundation of it all.
Well, thank you. And that means everything to us. And you mean everything to us. You've been a big supporter. You're amazing. And you're doing amazing things yourself.
Oh, thanks.
I a little bit about me. I'm a dentist, primary care general dentist. I have kids. So it's like I'm a mom first, as you know this, Meggie, we're moms. That's always first and foremost, and it drives pretty much everything in my life. And so I come from an adult dental sleep medicine background. So for 20 years, I've been helping manage CPAP intolerant patients with CPAP alternatives like mandibular advancement, stabilization devices. And then, I have my own kids, and I'm seeing all the things that I see in my adult patients, but in like an early form, and it looks different in kids, right? Like poor sleep in adults manifests medically different than poor sleep in children. They're not just like mini adults. They have different aspects that it affects. And so I was seeing that in my kids and went on this journey. Thank God I met Tracy Wynn and Michelle Weddle. And we put our heads together, our frustrations together, and our experiences together, and came up with ASAP Pathway. And I always like to say and give acknowledgement to Dr. Jameson Spencer, who was very influential in supporting us, encouraging us, helping get us off the ground. And without him, I don't think we would have done it, So he kind of was like the wind beneath our wings, and he's like, fly, you guys got this. So, I want to thank him for that.
Well, so interesting to me. Like, you think about some of the most passionate people about pediatric intervention when it comes to breathing and growth are our providers that don't necessarily primarily treat kids. And
100%.
And it's because we see, as general dentists, we see what happens when it's missed. And then as moms, we become super passionate about it. But really, it's the adult providers that are the ones that are like, oh my gosh, this is really important.
Agreed. You got Steve Carsonson out there who is beating the drum and making change. What he does behind the scenes, Meggie, I actually was on an email thread. Hi, Steve. Steve, I was on an email thread with Kevin Boyd and some other people. Were you on the thread? I don't remember. I just saw a bunch of people were on this email thread. I didn't know that, and I really need to be more careful before I start responding, reply all. But anyway, so I had a lot of caffeine. I was really kind of agitated about some things that I'm seeing in the pediatric airway space. And I kind of was like, oh my gosh. And I was emailing everybody. And then Steve Carstensen swoops in and responds like, I got this, like what he's doing with the American Dental Association and creating codes and the hours and hours and hours of like legislative, all the political stuff that's happening behind the scenes and corporately with the American Dental Association and the meetings, the things that move us forward, that put it on the map, the call to action to screening, like it's not like he just woke up one day and that happens. Like it takes a lot of hard work. So granted, they're not necessarily treating children in their practices, but what they're doing is affecting so many children around the world indirectly.
Mm-hmm. And we don't think about, or at least I certainly don't think about the background. I think about the dentists that we're exposed to on a daily basis and the patients that we're exposed to on a daily basis. But I don't think about these heroes like Kevin and Steve and Jameson and all these other people that are supporting those of us that are kind of on the front line.
Yeah, that's a good point. And when he told me how many hours to come up with a certain code, and they're looking into some other codes for, oximetry and stuff, like to have an oximetry code for a dentist, an ADA oximetry code, like that wouldn't have been even possible 10 years ago. Like why would you have that? So yeah, what they're doing behind the scenes, it was very humbling. And I was like, whoa, wow, because sometimes, my caffeinated self, I was like, why isn't this happening? And why isn't this happening and this happening? And it's kind of like, okay, it's taking its time, but change is being made. It's a lot behind the scenes that has to happen. We can't just snap our fingers. I mean, what we want so badly right now, it's coming. We just have to patiently go through all the hoops. So yeah.
For people like us that are hyper caffeinated or hyper strong, those of us that move a million miles a minute,
Yes.
or my husband called it 2.0 speed. It is hard to be patient, but it is nice to know that it's happening. But even looking at ASAP Pathway, for those of you that aren't familiar, providers, it's an amazing platform, community, and learning protocols for how to influence your own patients and bring this into your practice. But like you think about all of the work that you and Stacy, or you and Tracy and Michelle did, and that's not something that happened overnight. Like there has been hours and hours and hours and years that have gone into creating this. One of the things that I was really surprised about is I think I look at everything through the lens of my own perspective. And I thought that ASAP Pathway was, only for general dentists. And you shared with me that no, there's specialists on there, there's orthodontists, there's periodontists, there's pediatric dentists. Tell me a little bit about the demographic of the group that has come and found you and, created this community.
Yeah, it's an interesting journey as to what the demographic of what we affectionately, Meggie, we call everybody ASAPers. So the demographic of an ASAPer isn't who we thought it would totally be. Obviously, we're doing dental, facial, orthopedics, which would include orthodontics, orthodontists. We really thought in the beginning that the adult dental sleep medicine world would just be all over this because of what they're doing already. They already have the understanding of sleep medicine and, wow, just is this an easy transition?
And
but
it follows your pathway,
It
like
does.
you are. Yeah.
Right. Meggie, it's my path. It's a bit of Michelle's path. Tracy's definitely more restorative cosmetic background, then airway pros, and then into this. Because she was like restoring adults and asking the same questions about the anatomy and why aren't we doing this in kids? And, here we are using mandibular advancement devices, which are a CPAP or oral airway therapy, oral appliance therapy, to maintain a patent airway at night as a CPAP alternative. And we're just like, why aren't we addressing that in a child? but yes, it's the demographic really. I mean, we do have people in adult dental sleep, but my trajectory, it's just, I assume they're going to be like me, and it's not the case really, but it's bigger than that, really. We were
Okay.
told when we first started, we were told, here's dentistry, here's dental sleep medicine. I mean, let's go here. Here's dental sleep medicine within dentistry. And then here's pediatric dental sleep medicine. Like it was viewed as a niche within a small niche within an already small niche, but that's not the case. It is orthodontists, pediatric dentists, general dentists, periodontists, prosthodontists are interested. But I mean,
Even if
even
they don't have any interest in implementing the types of treatment that you teach, it's just the awareness of the connection to all of it, right?
yes, but what's funny, and you got a lot. We have a periodontist, and she is huge in like working. So now what she's been doing is educating her primary care dentist in her community, and she kind of hops around and she's placing the Marpies, and they're like, so it's like, oh, that's an interesting angle. Like what the ASAP community is doing blows my mind. Like you guys are, I just learned so much from everybody. Like last night there was an exchange, Tracy Tran, Joel D'Souza, like everybody was just talking, and I'm just blown away with the ideas that they're having and how to, change things with screening with children and the ideas that they're coming up with. They're really just bold leaders in their communities, such as yourself, saying, hey, this is missing over here. And then how can I take the knowledge I've gained? And I mean, the mentors and the leaders that have grown. I mean, the goal is kind of like a parent, right? You want to watch your kids like do better than you. Like, and it's just mind blowing to watch ASAP members that come in kind of like, I don't know what's going on. I just want to learn. And then fast forward 3 years later, they've got their own study groups in their communities. They're collaborating with ENTs. They're speaking at their local, medical schools. And I'm just
Well, the
so
same
proud.
way that Jameson was the wind beneath your wings, you guys are doing the same thing for all of us. You guys are so supportive and encouraging, and like the ripple effect of spreading the word and treatment options in the right way and research based and, collaboratively is, you'll never know the extent of your ripple effect. It's so cool.
I think thank you for that. Thank you for that. And it's funny, I was just giving an attaboy to a good friend of mine this morning who is celebrating his 19 years of sobriety and his vulnerability. I was just like, wow, you'll never know the lives you've touched by being so open and vulnerable. And I think that is
I
what
just had goosebumps.
yes. And I said, I'm always proud of you. But when I'm reminded of how far he's come, I just am glowingly proud of him. But it was funny that you're talking about ripple effect, because that is exactly what I was saying to him today about that topic. But it's the same thing, with all of us. It's being humble, vulnerable, knowing when, hey, like even within ASAP, we're not practicing the same protocols even 2 years ago. We recognize what's working. We recognize what's not working, what needs to be changed. And just, coming to the table and saying, look, we know this is a piece of the puzzle. And can we all just have just respectful conversations about it? That's what we're hoping we're doing. And then we're hoping that ripples to our members that then in turn have these humble conversations and dinners and maybe a Zoom meeting with an ENT in your town or a sleep doctor.
Well, it does. And, it also ripples to continue on the ripple effect. We have ripple effects negatively or positively in every interaction
Yeah.
that we have and every aspect of our life, not just in our professional lives. But, even from this scope of this podcast and talking about airway and patient health, we're also impacting the patients. And then the patients, their journey then ripples and impacts other patients, because if they have they end up in front of a provider that isn't willing to continue to learn and isn't willing to be vulnerable and understand that what they learned in residency or grad school is not the end all be all, and they're told no to something that is actually an issue, their journey might end. And if they're not exposed to somebody that's going to help quarterback or motivate them to keep seeking answers, they get stuck. But then their journey then influences their circles and the people that they are in communication with, right? And so like when they have good results or good feedback from providers, they get to help spread it even further. I always joke about how this is so like evangelistic out there, spreading the good word, but really it is such a cornerstone of systemic overall health, and it is still just so underknown. So the ripple effect is so important.
It is. And it's like, it really is unfortunate that it is so, has to be so grassroots, but that is where we're at. But it is changing. I mean, the fact that, you know, the AAO white paper, you know, they came out with another update.
Let's pause there for anyone that doesn't know about the AAO white paper. The first one came out, 5 years ago, I think, right?
Yeah, around that time.
And they came out with kind of in response to a lot of the grassroots efforts and groups that were spreading dysfunctional airway awareness to their patients, saying, hey, you know, basically orthodontia doesn't have a role in this, correct? Like, would you say that was kind of the basics of it, that if there's a breathing issue, it is a completely medical issue. Talk to a pulmonologist, a sleep doctor, or an ENT, and leave ortho out of it. Now, that might be an oversimplification, but that was kind of the gist of the original AAO paper. What Stacy's referencing now is just in this last month, they came out with kind of a update to that AAO paper. Now, go ahead, keep going. I just want to give people that don't know what the reference is.
Yeah, no, thank you for clarifying that. And, you know, the fact that they're even doing an update to the original paper 5 years later, or, you know, how many ever years later it is, says something. It says that the murmurings are still, the awareness, the murmurings, the demand for more information is there. And, you know, I will give the AAO this. I mean, they're trying to come at things from a literature base. This is what the current evidence is showing us. And, you know, some of the things that, you know, there are some things that are interesting, like you know, we were talking earlier, you know, kind of how they cultivated the research that they're presenting for their stance it's not all inclusive of all the research. And
they kind of cherry picked some of the articles that they shared in the paper.
Yes, which, you know, Tracy will say this, you can find any literature to support your, you know, what you're thinking usually. Right. So
is it sound literature? Is it sound science?
But is it sound science? Is it apples to apples, or is it apples and oranges? And you really have to, and thank God for Tracy. And she loves to look at literature. I don't know if she loves to. She's probably like, no, I don't love to. I just feel called to do it.
I'm so grateful that she does it.
Thanks, so Tracy. Grateful. Thanks, Trace. I'm grateful that she does it too. And it's something that she's really good at, you know, and, but she did a couple of, or 3 videos, which kind of just did some summations of.
I'll drop these links to Tracy's videos to her musings in the show notes below, because they're worth watching.
Yeah, they are. They're really short. I mean, they're just short and sweet and interesting. And, you know, it is interesting that, you know, here's what they're overall saying that is agreed on, you know. We cannot make claims that orthodontic interventions prevent or cure, standalone, prevent or cure OSA. Or sleep-related breathing disorders. Agreed. We cannot say that. We also know that as a standalone, we also know that, you know, nobody should be diagnosing a child with OSA other than a physician. This is our importance of our medical collaboration. But to say, yes, it's not a standalone, but it is absolutely a piece of the puzzle, because as I was saying earlier, to say we know there's a lot of risk factors with OSA. There's genetics, there's craniofacial phenotypes, inflammation, micronutrient deficiencies. We'll probably find something else out next year, biomarker wise, like, oh my gosh, this is another risk factor for OSA. And I keep saying OSA, Meggie, but it's not just OSA. OSA is like end stage of the condition.
It's end disease, right?
It's
You don't
end
need
disease.
to wait for the diagnosis of obstructive sleep apnea to begin treatment. That's what we're trying to
100%.
avoid.
Yeah.
We're trying to avoid an end stage disease.
Correct. And so, you know, sleep-related breathing disorders, upper airway resistance syndrome, mouth breathing,
Daytime dysfunctional breathing.
daytime, and let's get real, poor breathing at night. You're breathing poorly 24/7. It's just exacerbated because we're more vulnerable in our sleep and our brain behaves a little differently. And so the centers of our brain that normally keep an airway patent and during the day are a little different in our sleep during all the different sleep architecture. So, and there's different reasons for that. Could be micronutrients, could be other things going on, but a compromised anatomy does not help that. And if you look at all of the treatments for OSA and sleep related breathing disorders such as snoring in the 18 plus population, all of them, hypoglossal nerve stimulation, it's getting a tongue base forward. MMA surgery, it's bringing a maxilla and a mandible forward. Mandibular advancement devices, it is stabilizing and or moving a mandible forward. Anatomy, anatomy, anatomy. These are treatments for adults accepted by the medical and dental communities. And to say that anatomy doesn't affect an airway is ridiculous.
Correct.
So we can't say that. So I hear what the AAO is saying, you know, we can't say, oh, we're going to expand but we know there are phenotypes.
It's all about decreasing risk, right? Like increasing the room for permanent dentition or permanent teeth is going to be, at the worst, airway neutral. It's not going to make
airway
things
neutral. Yes.
at the worst airway neutral. So why not tip the needle towards ideal or optimal growth, knowing that we're not trying to cure, we're not trying to prevent, but we are trying to optimize and decrease risk.
And it's like the chicken or the egg. Is a child breathing poorly because they have a vaulted palate or because they have huge adenoids and tonsils that led to a vaulted palate or tethered tissues, which we'll get into in a little bit, that did not allow for the tongue to drive correct craniofacial development? It's yes and yes. It's
yes and yes.
It's yes and yes.
It's all part of a multifactorial puzzle.
Yes. And I think we're looking so linear at the body, like this led to this. The body is a symphony of just very complex growth and development aspects and compensations. And each person is different too. So, what we might see as, you know, a phenotype for, you know, at airway risk, which retrognathia, which the AAO did show, they cited a paper that listed, you know, mandibular retrognathia, intercanine width, you know, decrease intercanine width. So there are craniofacial phenotypes that go along with children. Yes. And I see them in my adult patients. I have 63-year-old men with vaulted palates, mouth hanging open. They can't breathe. They can't wear a CPAP because the CPAP doesn't go through their nose. We also know that there are papers. So like Tracy brought up, what they didn't cite were two recent papers in the ENT journal in 2023 and 2025, I believe. I think I wrote it down somewhere. Yeah, 2023 and 2025, the ENT journals, which show, yes, maxillary expansion improves nasal function.
And that, I mean, that's been around for a while. I mean, Audrey, you did a paper on that in 2017, that if you have a wider palate, you're going to decrease the nasal resistance. So it's so nice to have. right?
100%. And now we just have, and again, we are in a time where the literature is building,
Hmm.
but literature is not the only aspect of evidence-based medicine. So it's not just literature. It's you're using your knowledge as a doctor, your common sense. Hey, we got doctorate degrees and we all learned craniofacial development. And especially if you've continued your education, like I'm a diplomate with the ABDSM, I can use my logical brain that, what I've learned in sleep medicine and dental sleep medicine about anatomy, it is a factor. To say it's not, it is a piece of the puzzle. So it is interesting. And then they did talk about tethered tissues, which this is near and dear to your heart, with untethered. There's not enough literature out there. There's not any literature, really. They're saying there isn't literature that connects tethered tongues to OSA. But, and again, that is building. I'm sure that's building. But we also can look at the paper that it is interesting because Tracy said one of the major editors of the AAO update paper has their own paper in the Journal of Clinical Sleep Medicine that talks about range of motion and it's of the tongue and its effects on, airway and sleep health. But that wasn't cited.
Well, there is papers on that. You think back to Christian Guilleminault and the short lingual freedom and the correlation to obstructive sleep apnea. That's been around for a really long time.
True. That is so. Yes, there are papers showing, the anatomical screening, clinical presentations and correlations.
Correct.
But
we have to be able to start to piece together what, like you said, what does that mean? If you
what
have
does
a
that
short
mean?
lingual frenum, your function is going to be altered. And if your function is altered, your growth will be altered, or you can't get your tongue up and out. So like you have to be able to discern what do these papers say.
True, because you could have someone with maybe a short frenum with a crazy compensation of function, but it still should be a flag. Because if we know
it's a risk factor.
It's a risk factor, and it should be raising this tongue is tethered. It has a short frenum. Can this tongue be in the palate like it should be? Is it functioning like it should be? Is it myofunctionally sound? Is it compromised? So it should start us asking more questions. And I just think the paper that in the JCSM that about the range of motion was very much saying range of motion, their lack thereof of the range of motion and function of the tongue does affect airway and sleep health.
Well, and I know that orthodontists that have been around for decades, generations now, will also say that the range of motion or muscle function of the tongue influences orthodontic outcomes, right?
Absolutely.
So think about some of the earliest devices that prevent tongue thrusting.
Yes.
And they talk about doing tongue placement exercises to protect the relapse of ortho. So what is that saying? That's saying that we understand that muscles influence how the teeth and occlusion is and how the bones are stabilized. So like all of these things are kind of just like circling the drain, and we need to like connect the dots.
Connecting the dots. And I think, again, we're in a time where that is starting to happen, and we want the dots connected. But also, what doctors such as yourself are seeing with your patients, you cannot deny anecdotally even the experiences that you're having. And when you look at literature, and Mike DeLuke said this to me when I talked to him on a podcast few years ago, he's like, when you look at how literature was developed, it used to be developed out of private practice. It was more like private practice.
Noticing this. Yeah.
Noticing, I'm seeing this. Are you seeing this? I mean, this is just how hypotheses develop, and like, I did this and I got these results, and people putting their heads together and patient cases together. and reviewing those. And he said something about, it's interesting. I wonder if, like, with HIPAA, that has really changed how doctors can pull cases
I didn't
together.
think about that.
And I didn't either. And he said, so now the majority of your literature comes from a demographic based in the university. Well, the university is not seeing a typical demographic that a lot of primary care dentists are seeing. Where orthodontic literature is coming out of is typically a university, an orthodontic residency, and their demographics are mostly brackets and wires. The demographic is mostly a family looking to get braces a little more affordably, and they go to the local ortho school. Most orthodontists are not coming out with a lot of dental facial orthopedic training, definitely not behavior management in 3, 4, 5, 6-year-olds. I mean, they're mostly doing a little bit of phase 1 if it's extremely, deficient bone, and
even then there's a lot of foot dragging, and I get it because it's hard to manage that patient demographic, but like even then it's not robust.
It's even not, it's a good word. It's not robust. And I mean, and are they even looking at and asking the questions? So here's where I'm going to give all right to the AAO update. They want orthodontist screening.
Yeah.
They didn't say that now it's like, hey, you should be screening for sleep-related breathing disorders. Well, and some orthodontists don't even want to do that. They're like, whoa.
But what an awesome opportunity at the foundational community level. What an awesome opportunity. I think we're all ego-based, like a little bit, right? You don't get into this field without having some ego. And we all think we have to fix the problem on our own. But what if you're an orthodontist and you're like, okay, fine, I'm going to start to screen. I'm generalizing because I have some amazing orthodontists in my community that are wonderful. But I also understand now, I've kind of gotten this chip off my shoulder of like, why aren't you seeing 3, 4, and 5-year-olds? Well, now that we treat 3 and 4 and 5-year-olds, I get it. It's a really tough demographic. But what if you partnered with a pediatric dentist or a general dentist that treats this age group and says, hey, I'm going to screen for this. I don't have the resources or the want to do this in my practice, but you have the skill set for patient management. How do you feel about working with this demographic? And if that provider doesn't know, I'll help you. I'll, kind of bringing in and collaborating and saying, I'll do the cases that I'm comfortable with. I will even do the easy stage 2 ortho cases. You do the young kids. And that's a really nice way for the general dentist to bridge that gap of, hey, I'm seeing this in my practice. I don't want to do complex orthodontic treatment. I would love your support in doing early intervention. So, if you see this early, refer to me. Or if I see this and it's an older kid, let's start to work together. Like, what an opportunity, instead of all just kind of standing strong and saying, you're doing it wrong or I'm doing it right. We can start to pool these resources and actually help more people.
I totally agree. I say that all the time, like, especially the, 2, 3, 4, 5-year-old is, and the AAO says screen a child for orthodontic intervention by age 7, not at age, not at or after. It's by age 7. For some reason, people are forgetting the by age 7. Like they just hear 7, and it's like it's like they put in a lingual holding arch and just kind of wait, and it's like, oh, but I agree. Look, even if I've said this the other day, I was in another conversation. Look, you could be an orthodontist. You have all of the knowledge and tools and equipment and at your fingertips to do this amazing interceptive treatment that can improve nasal volume, and Stanley Liu said this, who are the rhinologists of a child? It's not an ENT. An ENT is not going to do anything to anatomically to change the anatomical structure of a nose. They're not. They'll do nose sprays, allergy testing.
ENTs are limited to removal, right? They can straighten or remove,
but they're not going to go in and
touch children.
No, and they're not going to do surgery on a nose. Correct. But the rhinologists of kids is anyone willing to go in and do dental facial, craniofacial orthopedics. That's who's changing the size, the volume of a nose. So to your point, I squirrel a lot. Sorry. To
Me
your
too.
point.
We're two squirrels running in circles around each other, having so much fun though.
I know, me too. To your point, what if that orthodontist is like, you know what? I will screen. And you know what? I would love to take over. You see this demographic that I'm not even really seeing anyway right now. And your average primary care dentist and pediatric dentist, your average, they just really don't want to do a whole lot of brackets and wires, and they just don't.
You can't, the two practice, I mean, just logistically, the two practice models don't work well together. Like an orthodontic practice model and a general or pediatric dental office model, they are not parallel.
They're very different models.
It's very hard to manage like broken brackets and wires and all these things over here that the orthodontist is really well equipped to do. And then having these other types of procedures that are done in a restorative practice. Totally. 100%.
Yes, it is. I mean, because, you know, I'm in the middle of an implant surgery. I'm going to go check a hygiene patient. And now I got to go, you know, and I've done it. And Meggie, dentists are doing it. And this is what the orthodontic community, it's not that we want to take away anyone's livelihood or we're doing it because they won't. So
I think that's such an important thing to pause on is I think that there's this mentality of scarcity that, gosh, if the general dentists start doing orthodontic treatment in their office, they're stealing from us. And I hate to think like that, but but
it is a real thing.
Let's assume that the general dentists have the basic understanding and knowledge to do the treatment well. Let's take away that they're not doing it well enough. Let's just talk about like the patient base. If you go outside, go to an airport, go to a park, go anywhere. We are living in such an epidemic of underdeveloped faces and jaws. There is never going to be a shortage of need to straighten teeth and have orthodontic treatment. Even if every single orthodontist or every single general dentist started screening or intervening early. Like it's just never going to go away.
No. And I had the honor to attend a Henry Schein orthodontic course that Dr. Sean Carlson, who is an orthodontist, it was years ago, and they only let orthodontists in, but Sean Carlson let me in. And I was so appreciative. And I was in the audience, and Sean was speaking to his colleagues. You know, he was like, look, he was speaking to the concern in the orthodontic community that Invisalign has been a game changer. The average bread and butter kind of easy class 1 malocclusion, general dentists are doing that now. It used to be everything was referred because dentists didn't want to do all the bracket wire stuff. And Invisalign has made it that, wow, I could actually incorporate Invisalign into my primary care practice. And he said, look, we need to set ourselves apart. If all we're going to do is phase 2, we're going to be dinosaurs. Phase 2, like braces, brackets, wires, and Invisalign. I mean, if all you're going to do is, put your orthodontic hat on that, you become a dinosaur. And he was saying, look, the general dentist is seeing, a mother pregnant, have the baby is about a year old. I mean, we're doing nutritional counseling. We're talking about pacifier use, breastfeeding. Like we are watching this child grow up, and we will do what we need to do to help this family. And we know that expansion improves nasal volume. We know this. We know anatomy improves an airway, whether it's negative, neutral, or positive. So his point was, get ahead of this and let's start talking more about our specialty. I mean, like all the orthodontists, like you guys, like I'm going to tip our hats. Like you guys are amazing. You have amazing understanding of growth and development. We're just asking, start screening, start looking a little differently because the current, if you go into your average orthodontic office, and like Mike DeLuke brought this up too, the amount of time that an orthodontist spends with that patient is very little. It's mostly assistant based, but even just like the upfront diagnosis and treatment planning, the average orthodontist spends maybe 4 to 5 minutes with the patient. What we're saying, and hopefully with this AAO call to action, start changing your health history a little bit. Start asking
Just
more
ask different
questions.
questions. Yeah.
Ask different questions. You might have a different diagnosis, which, Meggie, is scary for some. Like, look, when you're asked to change what you're currently doing, there's fear.
Change is so scary. Yes.
Change is scary. And so that's the human condition. And that's where the ego comes in. I don't want to change. Nothing's wrong with what I'm doing. If I change, you're telling me that what I was doing potentially wasn't the best treatment for my patient. Are you saying I could have failed people in the past? Like, there's all these questions in the human condition that come up with change. And we really have to get past that and just say, look, we know better now. We have a call to action from the ADA. You have a screening call to action now from the AAO. We can't keep our heads in the sand. We do need to ask more questions. I think if an orthodontist starts asking more different questions, you're going to come to different conclusions, and you might come up with different diagnosis. It might not be like, look, it's not that your teeth are too big for your mouth, it's that your bone is deficient. So why? Let's start asking those questions. Have they been breathing okay? Do they need to get to an ENT and have some allergy testing? How is their nasal function? Can they breathe well through their nose? Does their tongue even work? The tongue is your best retainer and your best orthodontist on the planet, or it's your worst retainer and your worst orthodontist on the planet. That tongue is everything in growth and development and sustainability. And if you've got a tongue as a train wreck and you've got nasal breathing issues, you're defeated before you even start with that orthodontic. You're not even addressing.
Those cases aren't fun either, right? Like, so not only are you doing a service to your patients and offering them a more sustainable, stable outcome, I can only speak from what I know, but like from a restorative dental patient base, patients that are high risk, high caries, recurrent caries, high risk for ortho relapse, those patients are really hard to treat and have them be satisfied or feel good about because they're never in a lower risk category.
Yeah.
So even from your patient or your practice satisfaction standpoint, as you, the provider, if you start to think differently and grow your awareness and grow your own knowledge base and treat slightly differently by asking different questions, you're not creating a problem that doesn't exist. You're becoming more aware of problems that are being missed. And when you start to identify those and fix those problems, the outcomes become better. It's a win-win. The outcomes become better for the patients. The outcomes become better for you. And it's an opportunity to start to collaborate with your other colleagues. And how much more fun is it when we get to do this stuff in community? Like, all of it's a win. Like, none of this has to be somebody was wrong. This can be a win-win-win-win-win everywhere, over and over again.
Yes, that's well said. A win-win-win-win all around. What's the harm in asking more questions? Oh, you might identify a kid that's not breathing and sleeping well, developing like neurocognitive deficits. I had a kiddo this week, a new patient in my chair, severe ADHD and medicated, and little brother's running around the room. The dad can't even listen because he's grabbing his kid constantly. And I could tell he wasn't really, it's just like, I want to get in and out of this office. Can you just do the checkup already? But I pull up the comb. I mean, she's mouth breathing. Her lips are fire red, and it's just, if I don't ask certain questions, I'm going to come up with a totally different plan for her.
Right. This child might have no caries. Okay,
she had no cavities.
Clean checkup. See you in 6 months.
Clean checkup. In and out.
In and out. Check.
But I ask questions. I see, does your child have ADD, ADHD? Yes. Is your child medicated for ADD, ADHD? Yes. Also, her mouth was extremely dry. So there is a dental health aspect there. So I'm trying to talk to him about maybe some, xylitol candies or xylitol based gums. And he's like, oh, she's fine. Anyway, it was kind of a very frustrating visit for me. And I could see it was frustrating for him because he wanted to get the heck out of the room. And
But you planted a seed,
I
right? And the
planted
next
a
time she
seed.
comes in or
But
he
here's what I
comes in,
did. Here's what we did. Does she snore or breathe heavy in her sleep? And he goes, nope. And the little girl turns around. She's so adorable. She's got glasses, like two crooked ponytails. And she just like turns around, looks at me, and she points to her dad. She goes, he snores really bad. And I said, oh, really? And then he goes, yeah, I have severe obstructive sleep apnea. And I said, well, you're snoring. So I'm assuming, are you in any treatment for it right now? He goes, no, I hate my CPAP. I go, well, I just want you to know, Dad, that the fact that you have OSA, there is a phenotype that your child has a high potential of having this as well. And what we like, if we could wave a wand, is every child with an ADD and ADHD diagnosis has a sleep consultation before medication. So I'm going to recommend, those are some huge adenoids. She's not breathing well. Her lips are chapped. You have OSA. She has ADD, ADHD, and is medicated. I'm just asking that we look at some other things. And then I said, with all this said, and then at the end, I'm like, I looked at her bite and she has a cross bite. So, I mean, it's just like, it's textbook.
I think for the providers that are listening too, like when you can align with a family, I think he's overstimulated. He's got two little kids. He's underslept himself. If you have the opportunity to connect with them, say, hey, I'm on your team here. I'm not trying to create a problem or more work for you. All I want to do is help uncover issues if they are a problem, or rule out that as part of her story.
Right.
And if we can uncover it, now we have different paths forward that are actually going to be less interventive and less costly and less traumatic for her. Or we rule that out. Right. You've already solved the problem with your medication and your diagnosis. But if I'm checking all these boxes, the responsible thing to do is to ask more questions.
Yes. And it's going to change. Yeah, it's going to change because her visit at the dental office up the street that doesn't ask questions about ADHD, they would have looked at her and said, because she was all over the place, even medicated, God love her, just sitting in the chair was so difficult for her. And it would have just been, get this kid out of here. Like, this is stressing my team out. Dad's like, get him out. No cavities later. But we are called, we know too much. We know too much. And it's, at this point, it becomes, to me, supervised neglect. To not
supervised neglect is such an important word that we don't use enough. And then, telling the family, and I don't know a parent that doesn't want an easier journey for their child. Hey, Dad, you're fine. You're doing great. You've got beautiful children. And I bet we can both agree that you've suffered greatly. You just said you hate your CPAP. What if she could have an easier path than you've had? Yeah. Let's think about what those options are and see if they're even accessible. Let's ask more questions.
And looking at Dad, he wasn't obese. He is a fit, thin man.
Probably would benefit from jaw surgery, right? Like, I don't even know, but I can picture his phenotype.
His phenotype screamed, I have sleep-related breathing problems or breathing problems, period. Mm-hmm. So I wasn't shocked. Well, man, when she whipped around,
she threw him under the bus.
I said, ooh, we're telling on Dad now. All right, And he kind of, the second he got pulled in, like, how's your sleep, And well, she told on him. And it kind of just, and he said, I have severe obstructive sleep apnea. And then all of a sudden you also have to meet people where they're at.
Totally.
And if
it's not a pain point for them, it's not an issue for them. It doesn't matter how much of an issue it is for us, but we can start to plant seeds and connect dots for them to ask different questions or think about it differently.
100%. 100%. And I mean, man, Stacy Becker 10 years ago with this, I mean, I would have lost so much sleep. I didn't get him to really, I think the seed was planted. He also was a very overstimulated dad with a lot to deal with. But today I'm like, like you said, I can't care more than they do to make something happen. And there might not be in a place. You just want to save every kid. I just
Well, and
want to,
I've also learned, like, I've slammed the door because I've cared too much or been too in their face about trying to fix them. And
yeah,
then they shut down. They are flooded, they shut down. And now I've lost the opportunity for
well,
them to get help in the future, even if it's not me as a provider.
agreed. And I'll be real transparent. I was so frustrated. I may have done some of that. Just it's like sometimes I just want to take these kids and say, "Hey, we're having a slumber party at my house. I'm going to just, you're going to spend the night with me tonight. Tomorrow morning we're waking up. I'm taking to the ENT. I'm going to fix you." Like I just want to fix them. And it's heartbreaking. I watch them get out of their chair and they get in the car with their parents who are like, "Whatever." And I'm like, "No, let me have them." But I do, I still catch myself, Meggie. It's like, breathe, 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 and my hygienist was like, "I've never seen anything like that." And he had such an attitude and he was trying to shut you down. And I said, "Yeah, but I will say, and here's what I say to parents. Look, sometimes I'll say this. I know we haven't even hardly talked about your child's teeth at all yet. And you're like, I'm in a dental office. Why aren't we talking about teeth?" And I say, I'm going to get to the teeth in just a second because the teeth tell a story. They're the side effect. The teeth are the side effect of all of this. So, and she had the crossbite, and that was the side effect of everything I was saying. But, I say to them, look, I am called as your child's healthcare provider to screen and look for different things. And like you said, and I'm going to start saying this, I'm on your child's team. I'm on your team. I want the best for your kid. I really do. And I'm seeing some things in the health history that are raising some flags. I'm seeing things, as we can see, because I have a huge TV screen with the cone beam up. I mean, like her adenoids were huge. And, her chapped lips. And I mean, it's just, it becomes so obvious. And, we get so passionate, but I have to put myself in check. My hygienist was like, that was the most frustrated I think I've been in years with a parent just seeming like they didn't care. And just
And we
like,
know that. Can you hear me okay? My
yeah,
headphones died.
yeah.
And we know that, right? We know that it's not that he doesn't care. We just know that. But
We know
it's
he
hard
doesn't
not
care.
to feel like that.
It does feel that way. Like I just feel, they're, and I even preach this, like, if you've got a parent that's sitting there in the operatory and they're like this, and they're
Checked out. Yep.
and they're like, you do the best you can. You planted a seed. Maybe they heard you, maybe they didn't, but it's documented. I've put it in our chart. And
And who knows if they see a different provider down the road or they have a pediatric appointment and it'll ring bells and it will stimulate past conversations, hopefully. That's all we can do.
That's all we can do. And it's a
all
journey.
we can do.
Yeah.
So I think the call to action today for this squirrely conversation that Stacy and I had so much fun doing, because it is, we can talk about this stuff forever and go down different pathways, is, wherever you are in your own journey, if you're a parent, to follow your gut and find providers that will listen. And if you're a provider, start to think differently. And if you're already thinking this way, start to connect with your community in a way that is collaborative and help break down the barriers to getting more patients the care that they need, and figure out what your role could be as an orthodontist, as a general dentist. Where do you fit into this grand puzzle so that you have the opportunity to help the ripple effects keep going? I love it. It's so fun.
That's a great take home from today. And I'm so excited that the change is happening and that the screenings are being asked of dental healthcare providers. I think at this point we know too much. We all should be screening for this.
I totally agree. And for all of you that are doing the work that's behind the scenes and thankless, like Steve Carsonson, thank you, because it really is impacting in a way that is not front and center or obvious, but it is so essential. So
Thank you.
Dedicated to Steve, huh?
This episode is dedicated to Steve Carstensen.
Brought to you by the letter, and I love it. Stacy, you're so fun. I appreciate your time so very much.
Oh.
And
Thanks
let's do it again.
me.
Thank you, listeners, for being here. And I'll put a whole bunch of stuff in the show notes today because we referenced a lot of stuff. We'll see you again next time on No One Told Us.
Thanks for tuning in to the Untethered Airway Podcast.
If today's episode helped you see things differently,
Please share it with someone who would benefit from hearing this. And don't forget to subscribe.
want to learn more about airway health or connect with our team?
Please visit our website, untetheredairwayhealthcenter.com, or follow us on Instagram @untetheredairway.
Until next time, bye.